There we go. Okay, thank you everyone for coming, and I will pass you over to Rachel to introduce this month's speaker.
Yes, thank you all for hopping on to this month's NETChatter event. We are very excited about today's speaker, which I'll introduce. Dr. Udhayvir Grewal. He is an MBBS at the University of Iowa. He did medical school in India and then came over to the US for residency, where he completed his residency at Louisiana State University. He is now a third year and during his fellowship in hematology and medical oncology. And he's last year's winner for the best oral presentation at NANETS. Today, he's going to be talking to us about the racial inequalities in neuroendocrine tumor clinical trial enrollment in the US. So we are very excited. And Dr. Grewal, you can share your screen.
Thank you so much for the introduction, Dr. Pointer. Let me see. Can you guys see my screen and the slides? Perfect.
Yes, looking good. I love this background.
Thank you. So I will be talking about racial inequities in neuroendocrine neoplasms clinical trial enrollment in the United States. Before I dive into the research that we did, I would like to give a brief background on the importance of race in neuroendocrine tumors and the data that we have so far. So just to highlight, I think we've come a long way since Dr. Obendorfer sort of took a stab at describing these unique clinical pathological entities called neuroendocrine tumors today or neuroendocrine neoplasms today, but back in the day it was carcinoid or a cancer-like and not even cancer. He used these 5 characteristics to define carcinoid, which we know are not true today, but this was definitely a step in the right direction to understanding and recognizing these clinical pathological entities. And then looking at the evolving paradigm of neuroendocrine tumor therapies, we've come a long way since the early 1980s, where we had minimally to moderately effective and highly toxic alkylating chemotherapies like streptozocin. Then somatostatin analogs came along, more alkylating chemotherapies, oral form, targeted therapies, and then PRRT. PRRT has been around for a while, but was only approved in the US in 2018. And then cabozantinib is the new kid on the block. So a lot has been going on, and we have a multitude of therapies approved for patients with neuroendocrine tumors. But the big question is there any equity here? Has this growth, has this development been equitable? And the answer is, I don't think we've looked enough to say yes or no. But there is some data that can at least give us some idea of, if this growth has been equitable or there is need to work towards more equitable growth in this field. I think Black patients with neuroendocrine tumors have been an unheard voice. And that is true for many cancers, but in line with today's theme, talking particularly about neuroendocrine tumors. Aretha Franklin needs no introduction, Queen of Soul. When I moved to the US, she was one of the first American artists I started listening to very seriously, and I'm a huge fan of her music. She unfortunately died due to pancreatic neuroendocrine tumor, and it was her choice to be very silent and not very vocal about her struggle and battle with pancreatic neuroendocrine tumor. But I personally, as a fan, see that as a missed opportunity to bring to light racial inequities and neuroendocrine tumors and opportunity for advocacy for equitable care. And there's a growing body of evidence that suggests that Black patients have more aggressive disease, and there is a significant risk of undertreatment. This seminal analysis by Dr. Dasari from MD Anderson showed that the incidence of NETs is rising and very rapidly. from some critics have commented that this is perhaps because of more modern imaging and our ability to diagnose these patients at an earlier stage. So we're diagnosing these patients more. But as many other analyses have shown that even if you adjust for those newer diagnostic techniques playing a role, there is a significant increase in the incidence of neuroendocrine tumors. And prevalence-wise, they're the third most prevalent GI cancers, talking about GEP-NETs. And if you specifically look at the incidence trends by race in gastroenteropancreatic neuroendocrine tumors, Black patients are right up there in terms of incidence per 100,000, and their incidence is rapidly rising. So due to this rapid rise in incidence, you would think that there is a rapid rise in prevalence as well, knowing what we know about neuroendocrine tumors. But I would like to ask the panel here, how often do we read about race being an important consideration in not just studying neuroendocrine tumors, but also treating them? And I feel like that is one area where there's room and scope to do a lot more research than has been done already. The Neuroendocrine Cancer Research Lab at UAB, in my opinion, has been a leader in at least trying to explore racial inequities and racial differences in the biology of neuroendocrine tumors. Dr. Winter is part of the lab, amongst other luminaries of NET research, Dr. Bart Rose and Dr. Chen. And their research has shown that there are differences, biologic differences between Black and white patients with pancreatic neuroendocrine tumors, be it survival of pancreatic neuroendocrine tumors when stratified by tumor size. We know that there is a direct correlation between tumor size and survival. And when you look at the median tumor size, between white and African American patients, there is a significant difference. African American patients tend to have a higher tumor size in millimeters compared to white patients. Then they looked at the AACR Project Genie database, and they tried to elucidate some differences, biologic differences between white and Black patients. The first thing that they've noted was there were only 26 patients out of almost 2,000 that were listed as Black. So that is a huge missed opportunity, I think, to elucidate differences, biologic differences between Black and white patients. But even with the limited sample size that they had, they identified that there were some key differences in the molecular alterations in about 9 molecular alterations between white and Black patients. And out of these 4, KMT, 2D, EP300, MEN1, checked to directly have a role in epigenetic modulation in pancreatic neuroendocrine tumors. So these are clinically meaningful biologic differences between white and Black patients. They also did some more analyses with their own patient samples, and they found that there was the key difference in negative staining of MEN1, which was more prevalent in white patients compared to Black patients. And early clinical data show that negative staining or loss of MEN1 expression tends to be associated with more indolent disease, although that can change if there is like loss of other proteins as well. But specifically looking at just loss of MEN1 expression, that tends to be more indolent disease. So that is another key difference, biologic difference between Black and white patients, as shown by their team. Further, they looked at RNA sequencing data conducted on 14 and 16 grade and sex-matched primary pancreatic neuroendocrine tumors from self-identified Black and white patients. And what they found was there were key differences in different pathways that were upregulated or downregulated between Black and white patients. Black patients had preferentially upregulated at angiogenesis or blood vessel and vasculature development pathway, and also a positive regulation of cell migration and locomotion, which, as you would know are associated with more aggressive disease. On the other hand, there was a downregulation of the humoral immune response in Black patients with primary pancreatic neuroendocrine tumors compared to white, which again would be associated with more aggressive phenotype. So this is some remarkable work that it at least lays the groundwork for future research, um, and at least shows in principle that there are biologic differences that may have repercussions in treatment-related outcomes and for Black patients with neuroendocrine tumors. And that's what we've seen with the limited data that we have. There is a direct impact on outcomes. And this study published in Journal of American College of Surgery by surgeons from UAB, Emory, and other institutions showed that with the current recommendation, where it is recommended to surveil patients with PNETs with size less than 2 centimeters and only operate if the size of the neuroendocrine tumor is 2 or higher, may risk the undertreatment of Black patients. And that is because they found that the rate of lymph node metastases in tumors that are less than 2 centimeters in size differ between Black and white patients. Black patients had 21% versus white patients that had 12% risk of lymph node metastases, which shows that all the guidelines, including specifically this one, may not be universally applicable to all comers populations, and there may be key racial differences. And it is not just an outcomes issue, it is also an access issue. If you look at the odds of undergoing surgery for guideline directed care for pancreatic neuroendocrine tumors, this analysis published in the HPP journal showed that on multivariable analysis, Black race was associated with a lower likelihood of surgery overall. And these are surgically fit patients based on the matched analysis that they performed. And you can clearly see that non-operative management was associated with a higher risk of death. So it reduced access among reduced odds of undergoing surgery among Black patients would mean that that risks worse outcomes overall compared to white patients among these patients. And if you look at all comers populations in pancreatic neuroendocrine tumors and not specifically just patients undergoing surgery, there is a clear difference in overall survival and pancreatic neuroendocrine tumor cause-specific survival between Black and white patients, with Black patients doing significantly poorly in terms of overall and pancreatic neuroendocrine tumor cause-specific survival. And this was an independent prognostic factor after adjusting for several other factors that may potentially play a confounding role. So these limited data at least give us an idea that there are key biologic differences. There are key differences in outcomes. Black patients tend to have relatively poorer outcomes compared to white patients. And there is a need to study these differences more and how they impact the care of these patients, and should we be adopting different approaches for treatment, both from surgery or systemic therapy standpoint for Black patients with neuroendocrine tumors. One thing that has not been looked at so far, and we thought was a huge gap in literature, was the representation of Black patients with neuroendocrine neoplasms on clinical trials in the US. All the therapies that we bring to our clinic are studied in clinical trials. And if these clinical trials are not well representative of the population that we treat, then there's a huge problem. Why is underrepresentation problematic? This seminal analysis by Dr. Narges Flores from Dana-Farber showed that this is a pervasive issue that affects oncology clinical trials, and Black patients compared to their SEER prevalence are significantly underrepresented on oncology clinical trials, and they have been significantly underrepresented over the years. And representation of these minorities, as I just mentioned, is important to allow generalizability of results to the general population. And underrepresentation of racial minorities is not just a problem with one specific cancer, it is across the board. And this may directly impact cancer care and outcomes. Another way of looking at it is access to clinical trials means access to novel therapeutic options. A lot of these meaningful treatment options that we have today were being investigated on a clinical trial once, and patients who were enrolled onto those clinical trials definitely benefited from being on those clinical trials. And if we are denying our Black patients the opportunity to participate on those clinical trials, that means we're denying them access to these novel, beneficial therapeutic options. So we try to take a stab at looking at this and at least helping our field identify this as a problem, as an issue. And we looked at clinicaltrials.gov database, and we looked at all completed US-based interventional clinical trials labeled as trials including patients with neuroendocrine tumors. And we then excluded clinical trials that did not have any NEN-specific information or included specifically some other rarer forms of neuroendocrine tumors, such as pheochromocytoma, paraganglioma, ACC, or Merkel cell carcinoma. And we also excluded trials that were purely diagnostic and did not study specific therapeutic interventions. So these were purely interventional trials. We also wanted to exclude based on grade and differentiation, but that is problematic because the WHO classification has evolved over the years, and the most recent classification was only adopted maybe a few years ago. And it would have been not possible or feasible for us to just include that pure well-differentiated neuroendocrine tumor cohort. So we could not exclude based on grade and differentiation. Then clinical trials were initially identified and included after initial review to obtain racial representation data by 3 co-authors, including myself. And then we divided racial categories into white, Black, and other race. Other included Asian, Pacific Islander, and other races. We then captured additional data related to clinical trials, such as what was a site, single or multi-center, funding source, academic, NCI, or industry. And how we label them as academic, NCI, or industry was trials that were purely funded, listed as funded by academic institutions, were listed as academic only. If they had NCI plus something else like academic, they were listed as NCI. Or if they had industry for funding in any form, be it industry and academic funding, we listed them as industry. And then we collected more data on phase 1, 2, or 3, and 4, and number of participants. To capture the changes after the 2009 NIH Health Revitalization Act, which mandated all clinical trials to report race and ethnicity data. We analyzed racial representation of these trials that commenced before and after 2010 to see how this the NIH Health Revitalization Act impacted the representation of minorities on clinical trials. And these are some statistical methods that we used. We used the chi-square goodness of fit test to evaluate differences in the composition of race in trial participants, that from compared to the reference population. And I forgot to mention the reference population that we used for this study was from a prior publication by the MD Anderson group that provided a racial breakdown of neuroendocrine neoplasms in the US using the SEER and SEER Medicare data. And we used their SEER prevalence per racial subgroup as a reference to compare if patients were proportionately represented on clinical trials. And then we used one sample z-test to evaluate which racial categories significantly differed from those of the reference population in the presence of a significant difference in composition. We also used a chi-square or Fisher exact test where appropriate to compare trial characteristics across racial subgroups. So we initially identified a total of 901 clinical trials in the database, out of which 88 clinical trials met the inclusion criteria. And the first big finding that what we had was only 37 or 42.5% of these clinical trials reported breakdown of participants by race, which again, if you compare to the work that was done by the NET team at UAB, when they tried to look at the biologic differences, Black patients comprised maybe like less than 1% of the cohort, which limits our ability to truly quantify these disparities. But hey, we got to work with what we have. So this was our first major finding, that most trials don't have appropriate racial breakdown of participants enrolled onto the trial. Then across those 37 trials, the median number of participants were 36 per trial. Most trials were multi-center, as you would expect with especially neuroendocrine tumors, followed by single center. And most trials were phase 2, followed by phase 3, phase 1, and phase 4. Most trials were industry funded, about 62%, followed by NCI funded and purely academic institution funded trials. As you can see, most of these trials, about 75%, were conducted or commenced after 2010. So a total of 2,000 trial participants, to be specific, 2,101 trial participants were included on these 37 clinical trials. And if you look at the racial breakdown, most of these patients were white, about 84.3%, followed by Black patients, and then followed by other races, and then Black patients. So the Black patients with NETs were the most underrepresented group, and I will talk about that shortly. The composition of race in the collected trial participants was found to be significantly different from that of the SEER data prevalence. As I'd mentioned before, we used SEER data from a prior publication by the MD Anderson group using SEER and SEER Medicare databases, and we used that as a reference population to compare what was the proportionate or was there a proportionate representation on trial participants on non-clinical trials. And we found that Black patients were significantly underrepresented. If you look at percentages, 6% versus 13% compared to their SEER prevalence. Looking at white patients, we found that they were proportionately represented, 84% versus 83%. So this identifies a big problem that that our non-clinical trials are significantly underrepresenting Black patients. And then we try to look at whether, other factors like source of funding, phase, and year of trial commencement had any bearing on enrollment by racial group. And we found that there was a significant association. Black patients had higher rates of enrollment in academic and NCI-funded trials compared to white and other race patients. And rates of enrollment in industry-funded or pharmaceutical industry-funded trials were lowest for Black patients compared to white and other race patients. We also found that Black patients enrolled in phase 1 to, when we look at patients enrolled in phase 1 to 3 clinical trials, Black patients were more likely to be enrolled on to phase 1 or 2 clinical trials compared to 3. And as everybody here would be aware, phase 3 clinical trials are where we compare an intervention to standard of care therapy. And those are required for full approval by the FDA in most cases. So Black patients are significantly underrepresented on those trials compared to phase 1 or 2. And Black patients were also more likely to be represented on clinical trials that were commenced after 2010 compared to white and other race patients, which tells you that trials are more diverse, perhaps after the NIH made this mandatory for clinical trialists or other stakeholders running the clinical trials to report the racial breakdown of participants being accrued onto their clinical trials. So just to conclude the findings of our study, we found that about 60% of NET therapeutic clinical trials in the US do not report a breakdown of participants by race. We also found that Black patients were significantly underrepresented in these clinical trials compared to white patients and patients from other racial subgroups. Factors such as funding source, phase of clinical trial, and year of trial commencement were notably associated with representation of Black patients. So the next question would be, what can we do? I think the first step in the right direction is to identify problem, and we've already done that. Our analysis shows that there is a clear problem. Then the next step would be to figure out a solution and finally achieve success. I adopted some of these recommendations from the ASCO and ACCC joint statement, which was published 2 years ago. And I think that is widely applicable to neuroendocrine tumors as well. We need to amplify and diversify accrual. And I think those need to go hand in hand. We not just need to diversify trial participation, we also need to amplify trial participation, which creates more room for diversification of trial participation. Clinical trials are an integral component of high quality cancer care, and every person with cancer should have the opportunity to participate. Trial sponsors and investigators should design and implement trials with a focus on reducing barriers and enhancing equity, diversity, and inclusion, and work with sites to conduct trials in ways that increase participation of underrepresented populations. Specifically for neuroendocrine tumors, sometimes accrual is slow because care is as far as like trial participation is concerned, I think that is limited to certain centers. And a lot of our patients who are being treated in the community, probably never get the chance to get enrolled onto clinical trials for neuroendocrine tumors. And also they're not as common as say colon cancer. So and not everybody meets criteria for accrual. So accrual can be slow and challenging. So these trials remain open for a long time. So if we deny accrual to certain racial subgroups for say 3 or 4 years until that therapy can be FDA approved, for that many years we've denied them a novel, effective therapy just because they didn't have access to that clinical trial, which I think is a huge problem. And then I think advocacy organizations in this specific area, of course, amongst several other areas where advocacy organizations like NETChatter Foundation and others can play a huge role in engaging with trial sponsors, researchers, and sites to form long-standing partnerships. And then lead from the forefront these efforts to diversify and amplify trial accrual and participation. And then I think any change, any big change, any meaningful change cannot happen without accountability. And we cannot put on that responsibility to others. Like if I'm running a clinical trial at my institution and it is an industry sponsored clinical trial, I can't think like this is the industry sponsor's responsibility to make sure that trial participation is diverse. It is also my responsibility. So all research stakeholders should collectively take this responsibility to collect and publish aggregate data on racial and ethnic diversity of trial participants when reporting results of trials, programs, and interventions to increase EDI. And last but not the least, I think we all despise these trainings and redundant educational courses, etc., that HR sends our way. But I think this is one specific area where these focused educational sessions or courses may be very helpful in terms of increasing the cultural competency of principal investigators or clinical trialists or other stakeholders in clinical trials to help mitigate this bias and develop important tools like effective communication to help mitigate some of these barriers that are perhaps preventing patients belonging to certain specific racial subgroups from being enrolled or accrued onto non-clinical trials. Our goal should not just be quality net care, but quality and equitable net care. And I included this picture earlier in my slides, and I think there's a difference between equality and equity. patients belonging to certain racial subgroups have been underserved for such a long time. They need that extra push. They need that extra advocacy. They need to have more voices in the room championing for their interests and advocating for their interests to bring them to a level where we can say yes, they're now we're delivering equitable net care. And often we use this term of zebras, like neuroendocrine tumors are zebras of oncology. I think it's time we realize that there are different colors zebras as well, and those colors have more significance than we thought they had. So I think glad we're talking about this and glad we're moving towards a common goal of quality and equitable net care. These are my acknowledgements. I would like to acknowledge the University of Iowa NETChatter for sponsoring the NET database and NET research group here at Iowa. My mentors, Dr. Chandrasekhar and Dr. Dillon, my clinic crew, and our research team. And specifically, I would love to thank Dr. Ear and the NET Cancer Foundation for giving me this wonderful opportunity to talk about my research and this topic that I'm extremely passionate about. Thank you so much.
Thank you so much, Dr. Grewal, for a fantastic presentation and using this opportunity to talk about a very important topic. At this time, does anyone have any questions? You're welcome to unmute and ask, or you can also type questions in the chat.
Yeah, thanks, Dr. Grewal, for representing the University of Iowa and really doing this amazing work and for the clear presentation. Also highlighting great work from Brandon, who's here with us too at this Zoom meeting here. Yeah, I found it really interesting that so it's really nice to see that the NIH has put so much effort and trying to increase diversity for the clinical trial accrual and everything. But unfortunately, like on the industry side, it was a bit lagging. And do you know if they started now to be more involved and actually is helping to push this, or what do you think of it, or with your interaction with them, do you think they're moving in the same direction as well?
I think that's what the word is, that NIH and NCI have taken multiple steps to focus on the diversification of clinical trials. Several steps like decentralization of clinical trials and involving multiple stakeholders. And as you must have noticed, there's more and more involvement of patient advocates and patients in, not just policy making, but also the design and conduct of clinical trials at the level of NCI and beyond. I think these are all big steps in the right direction to make sure that the trials that we are conducting and the participants that we are including are similar to the patients that we then treat in our clinics when we bring these therapies to our clinics. But I think despite all these efforts, there is a long, long way to go.
Thank you. And yeah, and definitely, I think you're right. And we're fortunate to have Lisa here who's involved in LACNet and really did amazing jobs with putting out even the information in different languages. And I think that's it's awesome, and I'm sure it helps to lift the field in that direction.
Absolutely. And I think those barriers are not just, at system level barriers. There are also patient level barriers. There are patients from poor socioeconomic areas. Patients may have language barriers and stuff. So it's not just one level that those barriers hit, it's multiple levels. And that's why we need more voice from patient advocacy organizations and patients themselves to make sure those barriers are addressed in ways that, patients agree with and would benefit most from.
Yes. Heidi, did you have a question?
That was he mentioned already in the answer what will be the solutions in terms of what are your thoughts and possible solutions about how we can involve more diversity in terms of race and sex and so forth. I'm at the NCI and I'm very aware of the initiative. And we're trying to promote as much education as we can, but at the same time, there may be different beliefs, from different race and culture and how to overcome that. So I think that maybe, a question, what will be the possible solutions for that? So that way we can include more people on different background, on different studies.
Right, absolutely. I don't think there can be one answer to that question. Of course, it's like a multi-pronged answer. In my opinion, I think outside of things that I mentioned, like education of research stakeholders and more accountability, I think we need to diversify the sites where we open clinical trials, and specifically talking about neuroendocrine tumors. For example, talking about my own institution, we have a diverse population that we treat in terms of like rural and urban, but we don't have that racial diversity here in Iowa. So I may include like 90 patients from here, 100 patients on the clinical trial here, and do great work in serving rural patients, but then that goal of achieving racial diversification of trials cannot happen if I just run my clinical trial here or at other similar sites. So I think I don't know how to put it, like a more well thought out implementation plan as to what trial sites should be included, keeping that in mind that if we include these trials, we will be able to achieve a target enrollment per racial subgroup. I think that would be an important step towards diversification of clinical trials. Like we look at, primary endpoints, secondary endpoints, and exploratory endpoints. I think this should be something, an endpoint, sort of a mental note in the minds of the clinical trialists, that we need to have a target enrollment of certain specific racial subgroups as well.
Yeah, I mean, a comment I would like to make is, yes, I think education is the key here, and especially at every state level, just because, I mean, there's so many factors, at least here in the States, right? It's kind of like what kind of insurance the patient have, and what insurance, can cover, what kind of tests can cover. And we know that molecular testing we like to do in all of them. And as Brandon, had a prior talk, I mean, there's different molecular and genomic profiling in different ways. But as we know, we try this to get paid by the insurance, there is always a lot of roadblocks and sometimes cannot be done. So, and I think that's kind of like one of the big issues too, that there is not enough. I mean, we need to kind of have more support at the state level. And like you say, there is different population depending on what state it is. In Iowa may be different than in Texas, and maybe different than LA, maybe different than New York City. So there's just different, in terms of race. And I think that in order to make some advancement, it has to be at the state level, but also at the national level, that be able to cover that as an importance on this effort. And again, what insurance can cover or not, this is something, many of the different roadblocks that we have, because even a patient may want to be enrolled in a clinical trial, but he cannot, pay for the medications or the scans, and the insurance doesn't cover. There is a lot of situations there, anyway, I just wanted to bring that up.
Absolutely. I think those barriers are important to identify, be cognizant of, and then engaging patients and patient advocacy organizations and other stakeholders in developing strategies to mitigate those barriers is paramount.
Brendan, did you have a question?
Yeah.
I just wanted to comment on what Dr. Del Rivera mentioned, with respect to the different struggles that you run into just getting insurance to pay for certain things. It's kind of interesting. Udhayvir, kind of showed some of the work that we did before, and one of the things that I found when I was looking at kind of the breakdown of these genomic studies is that a lot of them came out of the Northeast United States and Europe, where populations can be more homogenous. And it was an interesting thing to kind of think about, our population down here in Alabama for neuroendocrine, we're looking at 30+% of our population is African American. But, you also run up against these kind of political struggles where, for example, Alabama voted against Medicaid expansion, back in the day. And unfortunately, these areas within the Black Belt are oftentimes those that present those kind of systematic healthcare barriers to helping people get these treatments that they would need to be included in these trials. And that was a really interesting point. Udhayvir, looking into kind of your study, which was fantastic. I mean, this is really awesome data. Did you notice kind of any real patterns in kind of the geographic distribution of these studies?
That's a good question, Brandon. I think that's something that we would want to look at, but since a lot of these studies are multi-center,
Right.
it's hard to list. This is like a trial that was commenced in the Northeast or West. We could perhaps do that for single center studies, but again, that would be hard to tease out for, like, say, industry funded trials. So
Yeah.
that's something we wanted to look at, but hard to do.
Yeah, I think that will be, I'm sorry, can I make a comment? So I think
Yes,
that will be
please.
something that, needs to be done at the level of the NCTN. I think the NCTN should be able to help with a lot of that. So, I mean, you are at Iowa, I'm sure, I don't know what, what group you're affiliated with, but maybe that will be something that could be discussed at that level, because as you know, NCTNs, many groups associated with that, and there are hundreds of sites where they can have the study open. So I think that may be something that maybe need to look at, but at least we need to start somewhere. And I feel like even with the NCTN, you need to start at least to make the difference with, unfortunately, with the most common cancer. So that way you can go to the rare cancers. And the reason why is because sometimes even we have these hundreds of centers in the United States as part of the NCTN, not every center is able to open a study unless they can have the revenue from that. And an institution, they don't want to open a study if they can only enroll one patient a year, right? So it happened with the parafios. So that's why, even those, centers, they have some difficulty opening studies. So I think that we need to start somewhere. And I think that may be something to discuss at the level with the NCTN. And we may need to start with the most common cancer just to kind of have a baseline to then go with the more rare cancer. So that's one thing. Another thing I wanted to mention as well, because I'm kind of like I was very involved and kind of like bringing different patients and race into the NCI, and we were paying for travels and hotels and all that. But one of the roadblocks that we also encountered is that some patients, they don't want to travel. They don't want to travel because even though we pay for everything, they don't want to travel because it's like 3 days of work that they have to miss, and how they're going to provide, the means for the family. So is education, but at the same time is what the patients and means are. So I think that even though we are neuroendocrine tumor experts and we want to see that, and we kind of like know that this is an unmet need and so much needs to be done. But I think in order to start somewhere, we may need to start NCTN, maybe the project that you have, most common cancers, to then go to the more rare cancers, unfortunately. I wish it was different, but that's kind of like, because I was trying to also be involved a lot of that in the beginning, and I realized all the roadblocks that we were facing. So anyway, but I'm always happy to help, in anything I can.
Really appreciate that. Thank you.
Yeah.
Yeah, I think this is a fantastic conversation. I'll bring up one more point that Dr. Grewal mentioned in his talk, and this is something that I know Brendan found and something that we talk about a lot in our research, is the fact that a lot of people aren't, when they're publishing, even reporting racial demographics. I recently read a paper this week that they just said, 95% of our patients were Caucasian. and we had no idea if any of the patients were Black. And so it's very important, we believe, to push people to disclose what are the racial breakdown of patients in a study. We are going to struggle to identify the problem if they don't provide the data. So you had mentioned that, Dr. Grewal, and that's something that we run into a lot when we're reviewing the literature, that people are not even reporting what is the breakdown of the people that are in the study. And I think Brendan, when he did a systematic literature the majority of papers did not report race.
I agree. I think that is a big problem, and that is why the NIH and NCI is really pushing that at least it should be reported. So it at least helps us quantify the problem. I know that that is not always possible. When we were looking at some NET trials, like say NETTer 1, NETTer 2, these are global trials. So, of course, we cannot expect those trials, or it would be lovely to have that. But again, it would be hard to quantify the representation in those global trials. But at least the trials that are conducted within the US, single or multi-center, we can try our best to make sure that those are diverse in terms of accrual.
Yes, Heidi.
Oh, can I ask one question, and maybe on the kind of like what you of the research that you're working on, how many of those patients have the percentage that they didn't disclose race?
Sorry?
Oh, the percentage of patients that did not disclose race.
60% trials did not report racial breakdown.
Right, but how many of those patients did not want to report it? Because sometimes what it is that, now I'm not saying everyone, but some patients don't want to report race, especially more on the marginalized or more because they want to be alienated. They don't want to feel like if I do that, I'm going to have less chances. So some people, they just don't report it. So
that's a great point.
Right, and I've seen that in clinical trials, but surprisingly, we didn't run into that issue when we were collecting data. None of the trials that actually had racial breakdown, either in the form of an abstract or publication or on clinicaltrials.gov, had not disclosed or prefer not to disclose. But that's certainly a caveat for sure.
Yeah, but that's because you were able to collect that data because it was reported, or because it's a difference, right? Because whether the patient did not report it or you were able to collect that data because it was already reported, but maybe you're missing some that was not reported. I don't know if I'm making sense by asking that question.
Just to make sure I understood the question, there may be clinical trials where a certain proportion of patients may have not reported.
And you're only collecting the data of the ones that were reported, but without including the other ones. So that may be the reason why we don't know the percentage. You know what I mean?
Right. And I don't think that happened with our cohort because the number of participants were similar to the original N. So we were able to find, at least for the ones that we included in the trials that we included in the study, there was no discrepancy in the number of patients where the race was available, data was available and not available.
Yeah. But Heidi brings up a great point, something that, again, in Alabama we see is medical distrust, and how that contributes to the equities in trial enrollment. A lot of patients don't trust the system, and for good reason, especially here in Alabama.
Yeah, one of the world leaders that we had the opportunity to work with, who is really been kind of leading this charge in diversity and genomics of different cancers, prostate and breast, is Clayton Yates, and he was working at Tuskegee for the longest time, and was really kind of on the cutting edge of this stuff as a Black man, doing this research in that community. And so, that's always something that, we've had to kind of consider in evaluating kind of the genomic stuff. As in a lot of these cases, it may well have just been that patients felt uncomfortable reporting this stuff. And so I think that's another, thing that it's another obstacle that we kind of come up against.
Especially with neuroendocrine tumor, right? Patients who have been misdiagnosed for many years, bounced around and seen 5 to 7 providers before getting diagnosed. I know Pam Coons' fellow a few years ago did an editorial piece about his experience talking to NET patients in a patient advocacy group and how eye-opening it was to see the level of distrust. Yeah. And that's with Caucasian patients that he mostly spoke with, you know?
Yeah, that's a great point. Yeah, go ahead, Lisa.
I find actually when I first walked into, you know, a patient advocacy organization, I was not surprised, but kind of shocked to be the only person of color and the only person probably under 60. And it became my kind of mission to make that change, because how are we ever going to expect education, improved education and access and diversity in anything without changing the makeup of the advocacy organizations? Because we're only reaching the people already reached. So if we want to educate and improve all of that, like we have to change who we're reaching out to too from the grassroots level. And I always, Dr. Grewal, that was an excellent presentation. I especially always appreciate that picture of the people on the fence. Like it's going to take even more efforts, right, to reach them, like concerted efforts, intention, and how can we do better? And I mean, the first thing, like when I walked into the first patient advocacy support group, it's, you know, it was on Tuesday at noon in the middle of, you know, a city that served at a hospital that served, like, you know, the prosperity, you know, the rich people. So like we're never going to reach them if we expect them to come to us versus going to them. And how can we do better? Always, you know. So the first step is talking about it. I mean, both what you and Brendan are doing and talking about getting the data out, that's the first step, and we can all use that. And more communication about this. I know Dr. Udhayvir and I were both at INCA, and this is, you know, what we talk about. This is really important. But even when there's trials out there, nobody knows what the other hand's doing and where they are open and you know, what trials are open. I'm always running around trying to figure out what's the newest trial that's open, what's the latest data. So communication across the board so that we can all get the information out there, not just what the trials are, but sharing the information, making it patient friendly, inviting, as you both have mentioned, increased patient advocacy, participation from the ground up, which is happening and should probably be mandatory, but I don't think it's happening across the board yet, but hopefully we'll continue to do more of that.
Absolutely, I agree. This has been a fantastic conversation, an important conversation, and I want to thank you all for coming today, and a huge thank you to Dr. Grewal for presenting your work and summarizing all of the information of the field. So thank you all so much. We will have another one next month. Selena, would you like to say some final words?
I'm not sure what we're going to do next month. Normally we go into Net Cancer Day. We have patient stories session, so I think that we will be going for that for November, and we'll have some couple of patients to tell their story. But Dr. Gore, this has been fascinating. There's really excellent points made. I don't know how it works in the UK, whether we have the same issues. I know obviously geographically we are much smaller, and so someone who lives on one side of the country has no problem being part of a clinical trial that is the other side of the country, because from one side to the other we're looking at 8 hours, where you're looking at 8 hours to go from one side of one state to the other. So I think things probably are quite a lot different in the UK. So I appreciate learning that. That is fascinating for me. It's not something I actually thought about, so that's really interesting. But yeah, so thank you everyone for coming. That's amazing. Thank you very much for your talk, and we will be in touch about our patient stories, and everyone will get their email and their invite, and please look out on social media. And this video will be available from tomorrow on our YouTube channel, so please share with all colleagues, and tell your students, enrich all your students. And thank you very much again. I will see you all soon. Thank you very much. Thank
Thank you
you.
so much.
Thank you. Thanks. Bye-bye.